Welcome, everyone, and thank you so much for joining us today live or on the recording for episode 23 of Dr. Jeff Talks About Sex and Intimacy, the penile implant surgery. You know, it means so much to me that you have taken time out of your busy life to learn more about this subject, so thank you. We're on social media. If you didn't know, we're out there on Facebook, YouTube, X, and also welcome to our Kicks viewers. We are on Kick. And so we need 100 followers on Facebook. So if you're a Facebook person, please follow us on Facebook. We really appreciate you doing that. But we're out there on whatever your social media is. Go to the website. If you want to see some of the amazing, excellent previous episodes, they're all there. You can watch them on YouTube too. You can pull up the calendar, see what's coming up each of the upcoming weeks and what you might want to tune into. So please go to the website to find out more. You can listen to us in your car, wherever you are, we are. We're there with you on your favorite music streaming services like Spotify, Amazon Music, iHeartRadio. We're there if you're there. So I want to remind you as we begin, once again, that all are welcome here. Whatever your sexual orientation, whatever your gender identity, whatever your relationship style, know that you are welcome here to learn and be empowered. What's the goal of the podcast? It's really simple, and I try to start with this every week to remind you the goal is to empower and enlighten you with the evidence-based scientific information that you need to improve your sexual health and deepen your loving relationships, helping you live and love more fully. Today's episode, well, it's about a topic that often lives in the shadows, but it deserves open, honest conversation. And that's what we're here to do. We're going to talk about the penile implant surgery. The episode isn't here to persuade or to dissuade you about penile implants, what you should or shouldn't do. But rather, the episode is here to inform and empower you to make your own informed decision, because that's what you really need to do. Figure out if it's right for you. That's all that matters. We'll explore the good, the bad, and the real. The benefits, the risks, and the considerations, so that if you or someone you care about is facing this decision, you'll be better equipped to make a choice that aligns with your values, your health, and your goals. That's what's most important. Only a small percentage of men with erectile dysfunction ultimately choose implant surgery, but among those who do, both patient and partner satisfaction rates are high, between 80 and 88%. A lot of the patients will say to me, I don't know why I waited. I'm really glad that I made this step and did it. But again, nothing's for everybody. You got to determine what's right for you. After the surgery, though, you have to remember that your penis will not be the same. It is a permanent treatment. Even if you take it out, it will change the structures there. But again, most people are very happy with it and move forward with their life, and it functions well. So let's dive into what you need to know, so you move forward with clarity and with confidence and compassion. Dr. Kevin McVary is an internationally recognized urologist, surgeon, and researcher specializing in men's sexual and urinary health. And he is a personal friend and mentor of mine. I am so excited to have him here. He's one of my favorite people, and he is awesome. In the sexual health world, in urology world, he's the man. With decades of experience, Dr. McVary is a leading expert in the treatment of erectile dysfunction, benign prostatic hypertrophy, and penile implant surgery. He's authored hundreds of peer-reviewed publications and led landmark clinical trials. He's going to give you a little sneak peek of some things that they're working on now that have shaped modern urologic care. Dr. McVary was most recently at Loyola University Medical Center and is widely respected for his patient-centered approach, surgical expertise, and dedication to advancing the field of men's health through research and education. He's been my mentor and he's been my friend for several decades after we met and worked together at Northwestern Memorial many years ago in Chicago. So welcome, Dr. Kevin McVary. Thank you so much for being here, Kevin.
Yeah, Jeff, man, it's great to connect with you. And thank you so much for the kind words.
All true.
And also for reaching out and inviting me, because it's an honor to be on your show.
I was so lucky to have you as a mentor and a teacher, because you really, you've done it all. You were there doing the surgeries, working with the patients, doing the research that's needed to move us towards the future. And so I'm super excited to hear what you have to say. Let's get started with your presentation.
Okay, great. So anyway, Jeff asked if I would talk about the penile implant. And so forgive me if I get too jargony or too technical. The idea is maybe not to settle the issue, but maybe to help you understand what some of the issues are, how it works. And that would be kind of the beginning steps towards considering this really important step. So every talk should also, from a speaker, should have disclosures. These are mine, a bunch of alphabet soup, but what it really means is I'm involved in a lot of efforts, primarily sexual function, erectile dysfunction, and also prostate trouble. So that's really what all this means. So, this topic is prone to kind of humorous slides, and forgive me if this one isn't, but I think this is pretty much says it, basically erectile dysfunction being a lack of rigidity, at least rigidity to the point where the man can't be satisfied. Doesn't have to be perfect, but as long as he's satisfied, it's really not dysfunction. When man becomes unsatisfied, then that's really how we define it. Now, I'm sure Jeff has gone in his previous programs about various causes of sexual dysfunction. There is a little, acronym for it. And why do I am raising this on an implant talk? Because it's important. It's important to consider the cause of the erectile dysfunction before you would take a step towards surgery. There might be something unforeseen that could be reversed, and the entire dysfunction could be reversed, and penile implant surgery would really not be considered something you'd want to consider. So lots of causes. They range from systemic inflammatory problems. A lot of it is diabetes related, vascular related, neuropathic related, trauma related. They're kind of listed here, not to be comprehensive, but just the way urologists think, that an idea of the why is erectile dysfunction present, needs to be addressed, particularly if you're going to cross a bridge that you can't cross back on. And that's basically what penile implant surgery is. There's lots of ways to get to erectile dysfunction, is what I'm trying to say. And all these different factors, obesity, kind of the couch potato lifestyle, alcohol abuse, vascular problems, and certainly psychological baggage, psychological problems can initiate the problem and make it worse, to the point where men can become non-responsive to all therapy. So it's, again, important to consider those before deciding on a surgery. So a very common cause of erectile dysfunction is the diagnosis of prostate cancer or the treatment of prostate cancer. And it doesn't matter if it's surgery, radiation, or other hormone treatments, medical treatments. Just the diagnosis puts a man at increased risk of erectile dysfunction. And so, there are legitimate, very common side effects from prostate cancer treatment. And it's so common, I thought it would be worth calling it out. So on Jeff's show, I'm sure you've discussed the medical treatment of erectile dysfunction. And by that, I'm thinking of Viagra and the class of medications called PDE5 inhibitors, phosphodiesterase type 5 inhibitors. Men know the brand names, Viagra, sildenafil, Cialis, tadalafil. So certainly that is according to our guidelines. that is a first-line treatment, or at least the discussion of it is absolutely mandatory. And it's hard to imagine a man would come to a penile surgery without first trying that. But it's not a magic wand. The medication is not magic. And there is a large minority of men that do not respond. Someplace around a third of men who have organic erectile dysfunction, a physical cause, not psychological cause, a medical cause for the erectile dysfunction, about a third of those men are not going to respond to pills. Some men feel defeated. They feel alone when they're a non-responsive to pill. But that is actually really common. A third of men coming into the office are not, it's not going to work. And when you look at the large number of men with erectile dysfunction, here it's said 50 million, men that get diagnosed, it's a minority because a lot of men have it and they never see a caregiver, 30 million. And then the men that don't respond would be 10 million American men not responding to a PD5 inhibitor. That's a lot of men. There are other options besides surgery. Those have to be considered. I don't want to go into all of those because this is a penile implant talk, but just know that all those non-invasive techniques have failure rates. So what happens if man decides, hey, it's not working? Am I out of the game? The pills, I didn't respond to the pills. Am I out of the game? Well, it turns out there's lots of men that aren't responding, and someplace to medications, non-invasive techniques, and someplace around 20,000, 25,000 penile implants are done per year. That's a lot, but when you think of 300,000 breast implants done, that gives you a perspective of in the kind of sexual department by gender, that one has a very common surgical approach and then the other, it's very, very reduced. Like there's a huge drop off of men who have ED, fail, and decide not to proceed. So why is that? Why is it such a minority of men that decide to proceed? And I think that's part of why Jeff wants you to hear this talk today, to better understand maybe that reluctance to take the step is ill-founded, that maybe it should be considered. Again, before anyone was to consider implant, you'd want to do things to improve your overall health. And I know Jeff is an expert in this, the idea of improving your overall health, lifestyle modification as a way to improve or reverse erectile dysfunction. There is evidence to support that. And we have all these other different options besides the pills. But what we come to today is this, penile prosthesis. So what's an indication? An indication is like the medical rationale is why you could do it, why you should do it, why it is an accepted reason to do it. One is, as I've mentioned 1,000 times already, you failed to respond to a non-surgical approach. You didn't like the pill, you're scared of needles, the shot's out, whatever, just you failed. There are men who can't take those other techniques. There are men who cannot take a PD5 inhibitor. Let's say they take nitroglycerin, or they have a retinal disease where PD5 inhibitors are absolute contraindication. So it's a minority, but there are men that have a medical reason where they can't proceed with medical therapy. And those men, they'll skip the medicine step and perhaps consider surgery. There are men that take the medications and have terrible side effects. I get an erection, but I have such a severe headache, doctor. I don't ever want to have another pill. Okay, you're not managing it. You can't manage the side effect. Everything has a side effect, so do the pills. And then like the shots, some men have a lot of pain when they inject, not from the needle, but from the effect of the medication on the C fibers, the special nerves in the penis. And then there are some other situations, smaller, men who have congenital problems with the penis and erectile dysfunction, and the way to treat the two problems of the penis, the structural problems of the penis and the ED is simultaneously is to do an implant. That's actually pretty common, like Peyronie's disease, the curved penis. that can prevent men from having good sex. Sometimes surgery is a good approach for them. Okay, well, before you take that step, it's important to realize this is not a light switch. You have the implant and everything's groovy. So because sex, your satisfaction, your partner's satisfaction, the couple's satisfaction, it's complex. And so there's things that men have to consider. Post-operative pain and swelling. You have surgery, you're going to have some discomfort. And it's a special area, a sensitive area. And so that is part of the some men's reluctance to proceed. I think it's a small amount, but it's definitely there. We know that some men are reluctant because they know of complications. I'm going to go over that. But that's something that you just have to grapple with. You have a procedure, there's an accepted risk. It may be small, but it's not zero. And you are probably either 0% or 100%. You're not 2%. When side effects happen, they happen to you. So you have to understand that. Cosmetic outcomes. Some men, they have this idea that they have the surgery and they're going to be 19 again. Nope, sorry. Things change. Your hair gets gray. You get wrinkles on your face. And there is penile loss. There's penile change with age. A implant is a mechanical device. Mechanical device can have malfunction. I'll go over it. But that's part of the landscape. And then for some men, the ease of use. There's a mechanism for the device to work. And as simple as it seems to physicians and nurses and people in the field, a minority of men, but because you hopefully pick them right, that they have to have a certain comfort level with activating the device, and I'll explain that. And then the partner, the partner has a process that the partner is going through, he or she, and by that I mean some patients' partners have told me they're upset because they think that he's responding to the device, not responding to her, and there's a hurt. So that has to be kind of managed. That is not unwarranted because it is a different process, but still, as Jeff had alluded to, when men pick the device, when they decide to proceed, they are happy. They are satisfied. I have 98% satisfaction rates, and the partner's 96 right behind it. Jeff alluded to the very high A's. Those depends on which study you look at, but they have the highest rate of patient satisfaction. They have the highest rate of partner satisfaction, higher than pills or shots or anything. They have the highest level of recommendability to a friend. That's another measure of how happy they are. And also the highest, fastest level of spontaneity. Men that use the pill, no, you take the pill, okay, gotta wait for the pill to work. Or honey, I'm gonna give myself a shot. Here, I'm checking out. I'll be back in 10 minutes. Whatever, talk about a mood killer. But with the implants, it is much more spontaneous. Really, if a man is facile and comfortable with the device, it's really just a matter of seconds, not a minute, and he's ready for action. So it has a lot of advantages in that regard. All right, are there other potential things that you have to think about? Yep, Jeff alluded to it. Penile shortening. A lot of men will say, doc, it's not as big as it used to be. Grandma's house is not as big as it used to be. But there's a lot of explanation about why that may be. Remember, the man has had a period of inactivity, likely if he's getting the implant. And as men gain weight, penis is smaller. We say 30 pounds, 1 inch in both directions. So particularly if there's like the fat pad just above the penis, the peniculus, it's called, particularly that. If that's fat, then the penis actually, it's no smaller. It's just buried. And then certain types of causes of ED, like prostate cancer treatment, we know that those actually shrink the bulk of the penis. They affect the protein content of the penis. They affect the DNA count of the penis, and it shrinks. So a friend of mine did a study where he measured penises before and after implant surgery, and baseline, and then 6 months later, and said there really isn't much penile length loss at all. But most of the patients, 72%, said they perceived that it was different. So you just got to accept that there may be that perception. The important thing is, even though you may think, hey, it's not like it was 19, it still works. It's still satisfactory for him and partner. So you got to stay on the cup is half full, put it that way. Well, what's an implant look like? Well, this is one very early model. We still do some of these called a malleable prosthesis. And you can see it's like a bendable rod. I liken it to the, like at a podium, the instrument that holds the microphone is kind of bendable, malleable. It's just like that. Or some of those lamps that have a neck where you can bend the stem and point the light in a different direction. It's like that. It's certainly easy surgery for a surgeon. It's the least expensive, so sometimes medical coverage, if it's an issue, that covers it. It is firm. It may be bendable. It may be directable, but it is always firm. And when you compare satisfaction rates, they're not as high as the satisfaction with a newer type of device, which I'll explain, called a three-piece. But they certainly have the role, particularly men that maybe have some hand problems, manual dexterity problems. These are pretty easy to use. There are special circumstances I won't go into where we prefer to use these, and most men won't choose this. Most men will choose this other class, what's called inflatable. I'll get into that in just a second. But these are viable options for some guys, called a malleable prosthesis. It's about less than 5% of all the implants done are this, and that kind of tells you something. Well, the kind of mainstay of surgical treatment is called a three-piece penile prosthesis. There's two examples. The top one is this, we talk a lot in acronyms. This is the AMS, American Medical Systems device, and the one below it is Coloplast. They are essentially the same. There are some subtle differences. It's called a three-piece device, but count them. 1, 2, 3, 4. Wait, there's 4. It's a 4-piece device. Now, we call the cylinders are one component. Those are inflatable rods that goes in the penis. I'll show you that in a second. There's a controlling pump that sits in the scrotum, concealed under the skin. You don't look weird in the shower at the YMCA. And then the reservoir, which kind of holds the fluid in the flaccid state. And I'll explain this in a second, but when the man wants to have relations, he goes to the pump, presses it, and it's a hydraulics device. It transfers fluid from the reservoir through the pump into the cylinders. The cylinders go from flaccid to rigid and stay rigid until the device is deactivated, again, back at the pump, and she goes back. So again, this is the most common one done in the world, really. And certainly in the United States, it's 90, this figure says 96%, and that's probably right on target. Okay, you'll notice a color there, that orangey color, and this is clear. This is an antibiotic coating embedded into the substance of the implant. It prevents infection. I'll show you some information that says, wow, good invention. And then this device, you can't see it, has a certain coating on it where the urologist dips it in an antibiotic solution just before putting it in. And that also relates to lower infection rates. But again, we'll get into that. So the two categories is the AMS and the Coloplast. There's a lot of alphabet soup here, but there's a lot of different, there's several different models of these devices depending on the man's problem. Some are able to expand in several directions. Some have limited expansion, and the surgeon has to decide what's most appropriate for you. And again, this is not really a beginner topic, but a urologist who's comfortable with penile implantation will understand, based on your history, if one of these modifications is necessary, and that can be discussed prior. So here's the picture I wanted to show you. So on this side of the screen is flaccid, soft. This side is hard. Notice the penis is pointing towards the ground, and now it's pointing forwards. So what happens, again, the man, when he decides, hey, it's time, he goes to the pump. He presses a component of the pump that he can feel, and it's a chamber that transfers fluid from the reservoir through all the tubing into the cylinders. The cylinders fill higher and harder with every pump. So you go from flaccid to rigid, and it stays rigid until the pump is deactivated. So that could be 2 minutes, or that could be an hour. We don't like it if it stays up for hours and hours. There's an issue called erosion. I'll get into that later. But so the man doesn't, if longevity of the erection was an issue, this is curative, because you're hard until you say not. Again, it takes just a few seconds really to get this. Once you learn, this takes a few seconds to get it activated. So to conclude, treatment of erectile dysfunction, important issue, because pills, which are the most common and most appropriate first treatment, they're going to fail. They're going to fail in a third of the time. Other options may or may not be acceptable to the couple. And rather than to give up the game, there is a technique, penile prosthesis, which can keep the couple being active together. It's satisfying if patients are chosen correctly by the surgeon, and the surgeon presents the reality of the procedure accurately to both the partner and the patient. So that's really the implant part. Now, that device that I just showed you is essentially unchanged since I was a resident. I mean, there's bells and whistles, the antibiotic, reliability, all those things have improved. The antibiotic coating's new. So there are definitely changes, but substantially unchanged since the late 1970s, 1980s for sure. And so one might think, well, this is kind of stale. I mean, they're doing the same thing they did with great grandpappy. Well, not really. This is a graph. The green is what I want to draw your attention to. Those are peer-reviewed publications on penile prosthesis surgery. And when you look way back to 1977, there was nothing. They just start to appear in the 80s, and then they kind of get small, and then suddenly you start to see an increased number of publications. What does that mean? That means people are interested in it, that the field is alive, and that there are changes, there is an evolution that makes urologists want to write and publish new information about prosthesis. So in a sense, it's evolving just like many other parts of medicine. Now, I want to talk about some of the side effects. With infection, anytime a mechanical device goes into the body, there's a risk of infection. That is, that's just the way it is. If it's a cataract, if it's a knee, or a penile prosthesis. What is the infection rate? Well, inflatable infection rate, it says 4%, but if you look since 2001, that's when the antibiotics were embedded into the plastic of the device, it dropped from 4% to 3%, and now someplace around 1%. So that's a lot better than the previous 4%, 5%. So what does that mean, percent? It means if 100 men have the surgery, 1 man is going to have an infection. So not zero, low, but not zero. Malleables may have a slight increase in that infection risk. I mentioned this earlier, the idea of erosion. The device has to be chosen, measured on the inside of the penis. There's measurements that are made, and then the device is selected. They come in different sizes. The device is selected based on that measurement. And so you can't say, hey, doc, order me up an extra large, because you might not be an extra large size. He can't do that. If he does that, you get an erosion. in a sense, the device is too big for the space, and there's always pressure on the penis if the device is missized, and that pressure can cause the tissues to degrade, and the device itself will want to push out through the penis. It's not a good day if that happens. And someplace around 2%, which actually seems high to me, but because they're pretty uncommon in my own practice, but they have been. So if it's 2%, that's still too high. It might be a preventable problem. So the device match has to be done best, and experienced surgeons know how to minimize that risk. It's not zero though. And then it's a mechanical device. Mechanical devices can have mechanical problems. It's a hydraulics device. It pumps fluid from the reservoir through the pump into the cylinders and then back. They can leak. And that rate of mechanical breakdown in 10 years is someplace around 5 to 10%. So, and that's actually better than artificial knees, artificial hips, those types of things. Basically, mechanical things happen to mechanical things, and devices are not penile devices are not immune to this. And this is part of understanding. Well, what could happen? Not likely, but what could happen? You have to just accept that to get started. Okay, so that's kind of the state of the art. That's kind of where it is nowadays. And I mentioned that the field is not stale. The field is evolving. One such evolution is kind of what I call a newfangled type of implant. As I've mentioned, there's certain advantages to the inflatable device. We'll call them the pros. They look very physiologic. They're more flaccid. They're more rigid. But the surgery is complex. It's bigger surgery. You could have complications because it's bigger surgery. So the malleable device is simpler to put in, but there's increased risk of erosion. So there's not spontaneous. Patients say, "Hey, it's not physiologic." So we had this idea that we might be able to make a better implant using an entire different approach. So there's a type of metal called shape memory alloy. I'll show you an example in a second, but it's a type of metal used in heart valves, and when you get a stent in your heart, that's a shape memory alloy, a type of metal shaped that remembers several different positions. I'll explain what I mean by that. But we have this idea that we could use one of these alloys to make a better prosthesis, a simpler prosthesis, without giving up some of the advantages of what we currently have. So the reason the metal is interesting is that it has two different phases, or call it like two different crystal shapes. There's a very malleable type of metal phase of this type of shape memory alloy called martensitic. That's not important. And then if it's exposed to heat or magnetic force, the crystal structures change from very flaccid and soft to very rigid. Where do you think this is going? So we are developing such a device, kind of a new type of implant, where the implant can change its shape by exposure to a magnetic force, an external magnetic force. So the idea is you have this very flaccid piece of metal rod inside the penis. You expose it to a magnetic force from outside the penis, like take a magnetic wand, not a magic wand, and pass it slowly over the device, and that metal transforms from its flaccid state, the austenitic state, to the rigid state within a couple of minutes. So it goes from this to this. In a sense, the device unfolds and lengthens. So it gets girthier and longer as the metal remembers one of the other shapes it has. So it's kind of interesting. It folds on itself. So we've been testing this device, not in people. We've been testing it in cadavers and different things, about to start animal work, but we have shown that the device is at least as rigid as an inflatable device. And so very, very flaccid, but can be even more rigid than a current inflatable device. So pretty interesting. This is a video which we can't play, but essentially in the video I show a device. It's very floppy because it's in ice. We expose it to heat, and the device springs open kind of magically in a matter of probably 30 seconds is the time. So it's pretty cool. Pretty cool idea. It's been fun process. We know that if the device is inside, these are measurements, temperature measurements we made in the operating room on a man getting a device, a regular device, but we put thermometers in there and measure that if you apply heat to the surface, that you can cause small temperature changes in the penis that don't hurt it. We've tried to simulate this in the computer lab, where we make different designs and then test on the computer. We test them called CAD designs. And we've been able to kind of, I don't want to say perfect, but really made a lot of progress in device design by subtle changes in the design on the computer. We can anticipate what problems may be and refine the device even a little bit better. So we've been doing a lot of that. We've developed the wand, the magic wand, basically some AA batteries and a small magnetic coil, pass the penis through that, and the device activates. So it's pretty cool. Again, a video which I can't show. We have our device implanted in basically a hot dog, and made measurements of the metal. That's the nitinol, the metal part. When you expose it to a magnetic field, the metal inside changes temperature, but the temperature inside the penis and outside the penis doesn't change. So because this magnetic force, it's a very low level of force that's allowed to do this. So we have formed a company to do this. It's not available for men yet. We're still in the development stage, but the purpose of speaking it today is to just let you know that changes are afoot. And our team, myself and Alberto Colombo and Brian Lee, a urologist in the Chicago area as well at Evanston, we've formed this. And we've been lucky to have support from our colleagues who think this idea is great. Well, it says patients, but they're not patients because we haven't put our implant in them, but they're men with ED. And so I think, people, are excited with this possibility, this possible development. And again, I can't say that it'll be 3 years or 10 years, but just please know that the field is not stale. The field is developing. So that is my message, and I'm going to wrap it up.
Wow, so great, so much good information, and I love that. Before you even started talking, one of our listeners had questions for you, so I'll feed those to you in a minute about the device you talked about. So,
really?
Yes, so you were right on the money when we were talking about having that in there as well. So I'm super excited that you talked about it, because it's always fun to hear about new, innovative things and what cool technology. I love the magic wand, by the way.
Right, double entendre, but
absolutely, but so cool. I think some really important things from your message I really like is I think including the partners, whatever, in this decision-making process from the ground up when they go to put in that implant is super, super important. Because I think, like you said, they need to know what's coming down the pike for them as well and understand it and feel comfortable with it. So we really do encourage partners to come in with everything we do in the sexual dysfunction clinic and the sexual health clinic. And I think it's so important when you're going to do something permanent like a surgery, but with any choices that you're making when it affects your partner too.
Yeah, that's true. Yeah.
And then I really liked too how you talked about, I think with so many things we've had people talking about here, when Dr. Helfand talked about prostate cancer, when you talk about this, managing expectations, helping people understand from the beginning what's to be expected, so that then if they know their goals and we have these expectations and they meet, these are 98%, like you said in your practice. This is why people are satisfied. They know exactly what they're getting, and we're helping them understand that according to their goals.
Right. And it has to be repeated sometimes.
Definitely.
It's not just because, hey, I said it once.
Because what's so important, research, and you can see Dr. McVary is very heavily into research, and my PhD is in sexual health research as well. So I think it's so important to look at the research, and we remember about 10% of what we're told. Yeah. And when we're told this kind of information, there's a lot of stigma attached. Right. Yeah, it goes out the way. It's like, what did you even hear? So I think it's so important to repeat. And that's again why the partner, having two people there, my wife and I say together, well, maybe we'll remember, Right. So I think that's so important. When I wanted to make sure the listeners understood in that 3-piece too. So once it's all in there and you reach down, you're reaching down into the scrotum where it's like a third testicle, literally. Yeah. It feels sort of like a third testicle. Yes. And that's the pump that you pump to transfer the fluid out of the reservoir in your abdomen into your penis chambers to make it hard. So that's what you're pumping. And there's a release button on there too. So that's all within your scrotum. Everything's within your body, the cylinders, the pump, the reservoir. And like you said, it doesn't take long to activate. And if you were really concerned about it, just like you might already be hard when you walk in, you could have that thing activated before the sexual encounter occurs and ready to go.
Mm-hmm. Yeah. It sometimes takes some training, some extra TLC. Yes. But so be it. Some guys are fast learners, others aren't.
Right. And I tell people too, I always say, I kind of teach them this two-handed thing where you kind of secure it with one hand. So when you pump with the other, it doesn't slip out, because inside your scrotum, it's moist and it can slide out.
Yes.
Yeah. And it just helps avoid pain, and patients do really well with that. So I thought it was great. And then the malleable implant, I always tell patients, you can bend it out of the way, bend it up. Okay, if you're old school like Dr. McVary and I, you might remember on Sunday mornings, Pokey and Gumby, you could bend them into position. And I was thinking, I tell them it's like Pokey and Gumby. You bend it into whatever position you want. You bend it up when you want to have sex. You bend it out of the way when you don't. But not many people choose it. But we do have a few patients who, for whatever reasons, will choose that. The inflatable by far is the most popular. But wow, how exciting to think we have such cool technology, this new thing. I'm super excited about this shape memory. I think it's just such a great idea. So let me give you some of the questions. Sure. And so let's do the shape memory ones first, Vic. Great. He said, do you think there's a chance that this will reach market? Well, I'm sure Dr. McVary's hoping that it reaches market.
There's a chance. So yes, there's a good chance, but I think the key word is how many years.
Yes,
and it's not a million years, but there are key steps in the approval process, the FDA approval process to get it there, and we're not there. We're not where we can offer it to patients. I hope that's clear. My message is not, sign up. The message is, hey, the field is not stale. The field is evolving, and people are interested in it.
It's great that you're at the animal study phase. That's pretty cool. So that's exciting. But okay, people out there, the FDA, the different governing bodies, this is a process. So, and it's a painful process often, but it's an important process because we want to bring things safely to market. So,
That's right.
but it's
That's right. And that's
super
what they're
exciting.
about.
Yeah,
As
super
impatient
cool.
as we get, it's about safety of the patients.
Absolutely. Even sometimes patients will get frustrated, but I can do this. I can't see my penis because my belly's bigger, but I can do it. And we try it with the mirror, and I say, here's the thing. I want this for you as much as you want that I was referring to the injections when you have a bigger abdomen and stuff. I want it as much for you as you do, but my number one goal is your safety. I tell everybody, a dead man does not need an erection. So we got to think safety here, people,
Right.
So it is really, really important, but this is so exciting. All right. We had a question from the audience, and that was, so how natural, one of the people said, how natural does the implant feel during intimacy for both myself and the partner?
It's a great question, and a great question, and actually pretty common. So this is the way I say it. If it feels good now, it feels good after you recovered.
Mm-hmm.
But if erection, if sex did not feel good before, having the implant in there is not going to change that.
Mm-hmm.
So look at it as it's a way to go from soft to hard basically on command. But it doesn't change a bad marriage. It doesn't change a toxic relationship. It doesn't change a lot of things. So if ejaculation and getting an erection felt good before, it feels good after. That's what patients tell me.
You know what else too that's so cool about it is, let's say, women post-menopause, almost all of them have vaginal atrophy and dryness. You can adjust the hardness on this. If it's too hard or uncomfortable, they can pump less. There are things that they can do to tweak it, them and their partners, to make sure the comfort level is there for both people, which is cool about the inflatable implant.
Mm-hmm. Mm-hmm.
So I think that's really good. I had another question, a good one too. And this one was, if I get the implant, you sort of answered this, but if I get the implant, what happens if it fails or needs to be replaced later in life? What usually occurs?
Yeah. So, again, really good question. And I mentioned, there's a mechanical failure rate, low, but there. So what happens? Well, number one, you have to report it. And then the surgeon has to correct it. And there's kind of just algorithm he or the surgeon has to go through to say, well, what is the problem? Sometimes the guy's just pumping it wrong, but let's say it's not that, like re-education. But if it's not that, and there is, let's say, a leak, which would be the most common mechanical problem, where one of the devices connects to another piece of the device, you can get a leak there. That leak has to be repaired. If it's been very recent since surgery, you would actually just go in and fix the leaky spot. But if it's been years before it was leaking, what the surgeon would recommend is take all that out, put all new stuff in, like swap out, like one hose goes bad in your car, change all the hoses.
Mm-hmm.
It's that same idea. You swap it out.
I think that's really important. And think about it, like your furnace, sometimes it's got to be fixed, sometimes it's got to be replaced. Any mechanical thing could have those things. And I think it's really germane for some of our patients. I know with the VA and stuff where I work, it's like you have these younger guys who are getting it. And at some point, there's a good chance it will have to be replaced when you got it in your 40s or whatever, and you live to these days 90 or 100. But as you said, I've had HVAC things that have lasted 30 years. So you never know what's going to happen with them, but it may need to be repaired or replaced.
Yeah.
And
most never need a repair. But if it happens,
that's pretty cool. They have a pretty good track record, which is great.
Yeah.
So much good information. Wow, really packed in there. I'm hoping that you will agree to come back as we get closer and you can tell us more about what's going on with the research, with the new things as that is coming available, because it's super, super exciting. I love that shape memory concept. What a great thing. So that's really, really cool. I'm going to do a little closing exercise, and so we will come back to you. And also, Vic, do you want to tell them what's coming up next week?
In this fun and informative episode, Dr. Jeff is joined by Elise Fosnight, nationally recognized physician assistant and sexual health expert, to explore the empowering world of vibrators. They discuss how vibrators can enhance pleasure, support sexual function, and help people of all genders reconnect with their bodies, whether solo or with a partner. From myths and misconceptions to clinical uses and communication tips, this episode is packed with insights to help normalize and celebrate sexual wellness. Join us June 17th at 7 p.m. to learn more.
Those tickler videos are always entertaining. It's like, okay, that'll be interesting. But we have a great, Elise is awesome. She's going to give us some really good information, everything you ever wanted to know, but we're afraid to ask about vibrators next week. So as you know, we've had a lot of information, really good evidence-based, really good information about the implant tonight. But let's center ourselves like we always do at the end of the podcast. So that was a lot of technical information. Let's take a moment to pause and reconnect before we close. Just find a comfortable position, seated position if possible, whatever's comfortable. Let your feet feel the ground beneath you. If it feels safe, gently close your eyes. Take a deep breath through your nose and exhale slowly through your mouth. Allow your body to relax, your shoulders, your face, your chest. Relax, let go, release any tension or pressure. And you're just going to release any tension or pressure that you're feeling as you continue that breathing pattern. As you slowly inhale through the nose, and slowly exhale through the mouth. Repeat these affirmations silently or aloud. Why is it so empowering to explore all my options with honesty and openness? Why am I capable of making decisions that honor my health and my quality of life? Everything you need is inside. Gather the information you need and believe in yourself. Take one more deep breath in and exhale with a sense of calm and clarity. When you're ready, open your eyes, grounded. You're informed and centered in your own authority. It's been a great episode, and I thank my guest, Dr. Kevin McVary. Thank you so much for being here. It's been such a pleasure to see you again. Always, always a delight. And man, you packed us full of so much good information about this. Really helped us understand the risks and benefits and things to think about as men are navigating this landscape. Anything else you wanted to say before we close?
No, I would say don't give up. If it's important to you, ask. If you don't like the answer, ask somebody else.
That's good advice. Good advice. I thank you so much for being here. And I thank each of you for joining us and wanting to learn more about this topic. Thank you and have a good one.